All right, so a little bit about Blueprint, and this may seem a little salesy, but really what I want to do is I want to talk about a little bit of my background and what I do to help frame the conversation. Okay, so Blueprint is mostly a consulting firm. I actually lead the information security practice. So myself and my team, we go into whether it's covered entities or business associates, and we conduct the security risk assessments for those organizations. We have a pretty comprehensive approach to the way we look at security and privacy. We look at it from a bunch of different levels. We look at it from a very strategic level, which is looking at your policies and your procedures. More operational level, that's where we start looking at your facilities, and we start walking around talking to people. In our methodology, our approach is we like to be the opposite of an audit organization. We want people to feel comfortable when we come in. We want to have conversations, not with just the senior managers, the policymakers, but also your junior staff members, because we find that once we can get those people relaxed, we really find where the rubber meets the road when it comes to security and privacy and what's working and what's not working in an organization. So, like I said, I primarily focus on risk assessments and some of the different tools that you can use and different ways of approaching security from that strategic all the way down to that tactical level. This guy's really handsome. He's got a really spiffy bow tie on. So a little bit about myself. Again, I'm not going to waste too much time on this. I have a very interesting background. Started my career off in the United States Army. Got commissioned as a second lieutenant. I am currently still in the Army National Guard in New York State, serving as the Chief Information Officer for an infantry division there in New York State. My healthcare experience, I worked in Memorial Sloan Kettering Cancer Center in Manhattan in their security office. I've also worked for agencies or organizations like MetLife doing security risk assessments. So here are the learning objectives, and what I want to kind of cover here is the flow of the presentation itself. So I'm going to start off talking a little close to home, talking about Massachusetts, some of your state laws and regulations. Then I'm going to get into some more of the federal laws and regulations, the ones we're all familiar with, HIPAA, high-tech. And then I'm going to start talking about some of those other topics that you're hearing more in the news, whether it's breaches, the cost of the breach, what a healthcare record, one single healthcare record could cost to an agency. And really what I'm trying to do is I'm trying to frame the presentation to ultimately kind of slam dunk it at the end. We'll have fireworks, there'll be fire trucks, police cars, it's going to be fantastic. All right, so is there anybody familiar with the code for Massachusetts Regulation 201.17? Anybody? Okay. Can you tell me anything about it? There is no quiz at the end.
So I know, I mean, for us, it's more like mobile devices. We have to encrypt laptops, encrypt, storage devices, things like that.
So Massachusetts, in both a good and bad way, is ahead of the curve against the rest of the country. There's only 3 states, including Massachusetts, that have kind of stepped up their game and developed their own rules and their own regulations in protecting their citizens, both from a privacy perspective and a security perspective. So really what this code is telling you is that you need to report even further than what HIPAA requires you to report. The requirements in this regulation, this law, are very similar to what you would see if you were to compare both HIPAA and this regulation, but the reporting is a little bit different. That's the main thing I want to kind of bring out in these next couple slides. You'll see here, now HIPAA talks about EPHI and what constitutes that. Really, what Massachusetts has said is that if you have a breach or disclosure of any kind of information on a Massachusetts citizen, that's reportable. But here's the key. Where HIPAA says if there's a disclosure, an unauthorized disclosure at all, you have to report it. Well, Massachusetts has said it's not a breach unless it's used in an unauthorized manner. So if you have somebody who looks up their friend's social security number in a system, HIPAA would say that's a problem. Massachusetts hasn't really said that. It's unless that social security number is used in an unauthorized way. So this, I'll tell you that the slides I have are a little bit busy. And I try to distract you from the slides by walking around and shaking my hands and telling funny jokes. But here's the bottom line, is you need to have a comprehensive security program. What does that mean, comprehensive? It's a very subjective term, right? So really all this is asking you to do is what HIPAA is asking you to do, is have somebody who's responsible for security and privacy within your organization identify risks and address those risks on a continuous basis. That is the bottom line for the next couple slides that I'm going to tell you. But it's also going to talk to you about confidentiality, integrity of both electronic and paper records. Here's some more requirements. And again, these slides are going to be made available. I'm not going to read each one of these bullet points, but it's supposed to just give you an idea of the requirements of the state law. Now, I'm going to talk just a little bit about each one of these bullet points. And actually, before I do so, I meant to do this up front. How many of you have any kind of security background? Besides me. Okay. Any large hospital systems in the room? Okay. Mostly private practices? Okay. All right, so I'd like to do that to get a scope of my audience so I know exactly at what level I kind of need to talk about some of this stuff. Because I can get really geeky. I could talk an entire hour just on that stuff alone. So user authentication, really all this is talking about is giving people unique username and passwords so they can be identified in their electronic life as opposed to their real life. Access control. Access control is basically restricting people from getting places they're not authorized to be. And they do that based on permissions within whatever application or system you're using. Encryption. So encryption, everybody's heard it, everybody's kind of wrapped their heads around it from a federal and state perspective. Really, this is the whole point of encryption is to make data indecipherable if it's fallen into the wrong hands. Okay, so there's a lot of really smart people, I am not one of them, that sat in a room and developed all these crazy algorithms on how to encrypt data. System monitoring. System monitoring basically just says, we are going to look at the system to make sure that the right people are getting into the right areas and the wrong people are being kept out of those areas. It's being proactive. And I've got encryption here again, and really, I'm going to have to update these slides and just add it as one. One is for the network, basically meaning as you're passing data between organizations or even between staff members, that data is being encrypted while it's in transit. Then you've got the media. Media is talking about CDs, USB drives, portable hard drives, whatever it may be. Those laptops, those items, those devices need to be encrypted because they're the most easily lost. When I worked for Sloan Kettering, and this is a very outdated statistic, but it's one that I like to use. I did a class in 2008 while I was working for Sloan Kettering that said there was 12,000 laptops lost or stolen in airports a week. Alarming. 12,000 a week. So think about all the sensitive information that was on those laptops, and that's horrifying, right? So that's why everybody's pushing for encryption, because if those devices were encrypted, it wouldn't matter. So patch management. So everybody probably the majority of the room is probably using Windows machines, and you get prompted every month that there's new updates. That's all that patch management is talking about, is your vendors, your manufacturers of your applications and systems, they've realized that they're not perfect. They're people, they're humans. The languages they're writing these applications in, they discover holes or vulnerabilities in them. And what these patches do is they correct those holes or vulnerabilities. So being proactive and making sure your systems get their security updates and patches is pretty critical. Malware, That's malicious software. That's basically viruses, Trojans, worms, all those things that you hear in the news that are really scary because they can happen without you ever knowing. Having some kind of malware, anti-malware software is pretty critical. And then really, this is the one, I should have this in big blinking letters. Education. The fact that you're here is fantastic. I applaud each and every one of you. But what's important is you need to take this information back and you need to work with your staff members and educate them on what they should be doing, both from a security and privacy perspective. And I'm going to get into some of the things that Blueprint sees when we go into some really big hospital systems. What we see is a failure a lot of times in just plain education of staff members. All right, so really the only thing I wanted to kind of highlight in this slide is that the Attorney General and the Office of Consumer Affairs and Business Regulations is who you report any of those breaches to for Massachusetts. Now we're going to touch a little bit on the federal laws and regulations. So HIPAA, high-tech, omnibus, everybody's probably familiar with these names and these terms. So HIPAA signed into law in 1996, then came high-tech as part of ERA. Really what high-tech did for you is it increased the maximum penalties that could be implemented on an organization as a result of a breach. It also increased the reporting requirements. So not only do you have to report it to Health and Human Services, but for anything over 500 records, you have to report to media outlets. It's all a part of that education campaign to get these individuals whose information was disclosed, get the information out to them that it was disclosed so they can be proactive in protecting themselves. I personally have had my information disclosed 6 times. 6 times. I think mostly by the federal government who's lost my information. What high-tech also did is it gave the state attorneys general the ability to bring legal action against organizations. So it gave them a little bit more teeth in penalizing those organizations that have a breach and more than likely in a neglectful way. Nobody's really going to hammer you if you were trying to do all the right things and you had a breach. It's when people willfully neglect and don't try to do all the right things that you're going to see some of those higher and those stiffer penalties. So here's just a breakdown of those penalties. Another great thing that high-tech did, and it made hospitals and private practices, it gave them something they needed, is it actually defined that business associates and subcontractors are now subject under HIPAA. So now they had kind of some skin in the game to do all the right things from a security and privacy perspective. Pre-high-tech, your vendor, there was no reason for them to have to do the right things and implement security measures. If you were outsourcing billing or something like that to a third party, they could lose your data and there would be no issue with that. High-tech has now said that there is an issue with that. They are now covered under HIPAA. All right. So everybody likes to think that omnibus is a law in and of itself, and all an omnibus is it's the enactment of a law that was already previously signed. So all this omnibus did was make it official everything that high-tech said it was going to do. All right, so this is me being clever. So why are we here? Why am I telling you all this? So here's some numbers. This information is from 2014. I'm actually looking for an updated 2015 study. But here is your global cost per record. $145 per record costs an organization if they have a breach or unauthorized disclosure. $145 per record. So think about some of those bigger breaches out there, the ones that 500 million records. You do the math, I'm not that smart. This is the number, average cost per incident for an organization to respond and deal with that breach. 3.5 million. This is why we're here. For healthcare, it's $359 per record. And that's because of those slides I showed you earlier with the penalties under HIPAA and high tech, right? Here's different types of attacks. And here's some things you can do to try to reduce those costs. And really all this is telling you is if you do some of these things, if you build a strong security posture, if you have an incident response plan, if you actually hire somebody that understands security and technology, what it does is it reduces your surface area because then you have somebody proactively trying to address these issues. If you don't, then your surface area kind of is increased. I'm not going to spend any time really talking about the quote-unquote wall of shame. Really, and this information is actually outdated because I submitted these slides, I don't know, 2 or 3 weeks ago. 1,366 reported breaches of 500 records or more since 2009. There have been 224 since March of this year. What does that tell you? It means healthcare data is being targeted. Why do you think that is? Can anybody tell me why they think in the back?
Because the cost of a credit, what I've been told is the cost of a credit card record out on the street is $100. The cost of a Medicare record is like $50. So there's a financial incentive, huge financial incentive to get that data.
Absolutely. And why do you think it's so much more? And this is really what I'm driving at.
Just identity theft. You can steal a person's identity from the information there.
Well, it's a very comprehensive record, right? There's a lot of information about somebody. If you steal credit card data, you don't have as much data on that person than you do in their medical record. There's a lot of different things you can do. You could file false Medicare claims, right? You could file false tax returns. In worst case scenario, and this stuff actually happens, and if you want, I will send you proof that this stuff actually happens. You could go into a hospital and claim to be someone else and get treated. And now, if I was in there, say I was HIV positive, I went into the hospital, I got treated. Now the person I stole is HIV, their identity, now they're HIV positive. I've read stories about mothers who had Child Protective Services called on them when they brought their child to the hospital because someone went in as them who was a drug addict. So that was in their medical record. So as soon as the hospital saw that this parent was a drug addict, Child Protective Services was called because here's the child in the hospital and has something wrong with them. Think about that. That's horrifying. Talk about long-term patient safety. That's really what we're talking about here is everybody thinks that security and privacy is an IT problem, but it's not. It's an organizational problem, right? So everybody's got to do their part to protect those patients. And what we're looking at here is not protecting them against what is ailing them today, but long-term wise, what effect could losing this information have on those patients? Okay, so just here's some examples of what you see on that website. All right, so I'm going to get into some myths and facts that's published about meaningful use. You can see them on the CMS website. Now this is where, if you got something burning, feel free to chime in. I'm not the smartest person in the room, I can tell you that. The Army taught me that. I am definitely not the smartest person in the room. So if you have any specific questions about what I'm about to say, chime in. All right, security risk analysis is optional for small providers. False. Does that surprise anybody? Okay, good. Installing a certified EHR fulfills the security risk analysis MU requirement. Does that surprise anybody? That is false. Okay, this is good. You guys are a very smart crowd. My EHR vendor took care of everything I need to do about privacy and security. False. Your vendors, from a financial and business perspective, they have a reason to want to do those things, but it's up to the organization to address everything when it comes to what's required for meaningful use and HIPAA from a security and privacy perspective. Because what a common misconception, and since you're all very smart in this room and you've proven that to me, common misconception is that you only kind of have to look at the technology, the platform itself. Well, as soon as you install that platform, that application, people are now starting to interact with it, right? So out of the box, that application may have met all the requirements, but the moment you have people start interacting with it, it becomes a bigger beast to kind of wrap your head around, all right? So what are your processes and your procedures for interacting with that application or even sharing information? The moment you pull a record down, it increases your surface area. There's something you need to address. I have to outsource the security risk analysis. Now, me being an information security consultant, I would love for this to be true. But this is also false. This can be done in-house. If you have a parent organization of any kind, it can be done by them, and you can be given the results of the report or what have you. There's nothing saying that you have to bring somebody in from the outside to do your security risk analysis. Checklist will suffice for risk analysis requirements. False. Checklist is a step-by-step process, but you're not really digging deep enough, right? Me as a information security professional, I'm kind of like a detective. I'm an investigator with a flavor of audit, right? So my whole job is to go into an organization, ask some standard questions, but based on those answers, I'm going to dig even deeper, right? Until I get what I want, or I'm shown that I can stop digging, right? So a checklist doesn't really do that. So it's got to go beyond that. There is a specific risk analysis method that I must follow. False. So that goes back to my last comment about being an investigator. Information security and privacy, it's not rocket science. It's a lot of common sense type of stuff. So understanding where your data is and where it's going and who is touching it is what you need to do to kind of develop your methodology to assess risk. So are there any vulnerabilities in the way that data is passed and utilized that could present an unauthorized disclosure? I mean, everybody in this room could probably figure it out. I like to pretend that I'm really good at what I do and I'm the only one that can do it. But ultimately, if you know that you're taking patient information and you're emailing it to your personal Yahoo or Gmail, it's probably the wrong thing, right? Everybody in this room knows that, but that happens. That happens all the time. So understanding your specific environment, your organization, is how you develop this methodology to conduct that risk analysis. What I tell my clients before we even go into an organization to do a risk assessment is I say, hey, listen, I want to be a part of your team. I want to be your partner, which is really great sales and marketing. They chew it up. But what I really mean is I need to be sitting next to you on the bench and understand the culture and the environment within your organization in order to really understand where risk may reside. Because there's a lot of companies or a lot of organizations that I've gone into where the organizational politics has a direct impact on security and privacy. So for the bigger hospitals that may be in the room, your CEO couldn't care less about security and privacy. So guess how many people are probably going to be looking at it? Very few. For the smaller private practices, if the doctor doesn't get the importance, and the practice is probably not gonna focus on it. So that's political, right? So understanding those politics is critical to really understanding what needs to be done to address the risk analysis. This one's kind of redundant. My security risk analysis only needs to look at my EHR. The answer is false. Again, for meaningful use, CMS has basically said that it needs to be focused on the EHR, but it does go beyond the four walls of that application. You need to understand, who's touching that application, where the data is going, and what protective measures are in place. I only need to do a risk analysis once. Anybody want to take a stab on why that is false?
Things change.
Things change, absolutely. People change, the environment changes. Your vendor may have released some huge upgrade that you got for free, which would be awesome. HIPAA specifically tells you need to have a continuous analysis of risk. It's a continuous program, okay? So what you can do is you can do a thorough risk analysis and then review that analysis on an annual basis to see if there's anything that has changed. If nothing has changed, then you basically would formalize that review in a memo or something so that you meet the requirement of that continuous analysis or that continuous program to address risk. All right, so 10 myths. Oh, go ahead.
So our organization's outsourcing our security risk analysis, and the EHR that we use for meaningful use isn't currently in scope, but they're going to be reviewing 3 of our other EHRs. Now, would that satisfy the meaningful use requirement, because it's still reviewing our, policies and procedures and, access control when it comes to the network? I mean, does that, it's kind of a gray area.
Yeah, I would be weary, because if their report specifically says it's out of scope, then if OIG or somebody came in and audited you, I would if I was an auditor coming in, I would have a problem with that. Be like, well, you never even looked at your main EHR, so how can you say how can you attest to meeting that core requirement?
That's kind of what I figured you'd say, but I'll take it on no one to someone to get that figured out.
Well, so there are ways. I don't want to speak out of turn, because I do not work for CMS, and I don't want to ever claim that I know exactly what they do and how they do it. I would work with your vendor to maybe craft some language in the report that speaks to what they reviewed that is connected to that EHR. So policies and procedures on how to interact with that EHR, the training program, blah, 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 blah. Maybe they're not looking at the specific, permissions and access control of that application, but there may be some things that can help your case.
Sure.
You know what I mean?
Thank you.
Okay, apparently there's 2 more. So before I test for an EHR incentive program, I must fully mitigate all risks. False. So not only meaningful use, but HIPAA, they're not telling you that you have to have everything you identify fixed immediately. What they want you to do is identify a corrective action plan and have a roadmap to correct those issues within a reasonable timeline. So, you may not have the money to spend to correct, you don't have a firewall or something crazy where it's hundreds of thousands of dollars to implement, or whatever, even tens of thousands. What your plan might be is we have to wait until next year when I can put this in as a capital budget line item to get it, purchased and installed or what have you. There has to be a plan. As long as there's a plan, then most auditors are not going to have an issue with what's going on. So the last one, I have to completely redo my security risk analysis. As much as I would recommend this is not a requirement. You can do a review of a previous risk analysis as long as there's no change in your environment. See how I'm doing on time. All right, so this has got a slide all to itself because it's pretty important. Yes, sir.
back to that last slide. Go back to the last slide for a second. At the bottom. So, if you said if there's no change to your environment, you can review your previous security assessment, and I would imagine you could continue to implement it if you haven't implemented it fully. But if you had a change to your environment, can you restrict your new analysis to just that change in environment and continue to go with the old analysis and implementation of changes from that, plus an assessment of any change? In other words, you don't have to redo the whole thing just because you had a change in your environment. Let's say you've implemented tablets where you didn't have tablets before.
Yes, and that is a without all the facts type of answer. So I would say that any change in the environment, you can do an analysis just on that change, but it's still got to get linked back to your previous.
Yeah, incorporated into the full
Right.
analysis and plan.
And I'm glad you asked the question because it's prompted me to make one other comment on this. When you do your review of the previous risk analysis, there needs to be some kind of formal process that adheres to. It's not just a, I read the document and we're all good. There's no issues. There needs to be some kind of official memo or something on letterhead saying that this was the process that we went through to review this, and someone of some kind of authority should sign off on that, saying that this was completed. Does that make sense? It needs to be something formal, something concrete, as opposed to just saying, yeah, we did it, but you can't prove it. Because if an auditor comes in and you can't prove it, it didn't happen. Okay? Did I answer your question? All right, so nobody's going to solve this problem for you. It's up to physicians and their staffs to make sure that privacy and security are being addressed within their organization. Okay, security risk analysis. So you've got your physical safeguards, your administrative safeguards, technical safeguards, and then you're also looking at policies and procedures, and then this organizational requirement, which is one that's kind of often forgotten about, and that's referring more to your business associate contracts and other types of contracts that need to have specific language in them to address privacy and security. So this is gonna dig into each one of those categories, those 5 categories. What I want to kind of highlight here is your risk analysis. Conduct an accurate and thorough assessment of potential risks and vulnerabilities to the confidentiality, integrity, and availability of your EPHI. But then also, that needs to be a part of your risk management program, okay? So the risk analysis is just one step. All right, your risk management program is it's that continuous cycle. So you've identified where your risks and your vulnerabilities are. So what? So what's next? What are we doing? And that's that roadmap that I had talked about. You need to have a plan on addressing those risks and those vulnerabilities to make sure that they're mitigated, reduced, or completely removed. So HHS has put information out on ways of conducting a risk analysis. What you want to do is you want to define the scope. And this goes back to your question about your HR. What's in scope in your risk analysis and what's out of scope? So is it every application that you use? Is it, or is it not? Is it every employee? Is it every facility? Maybe there's a facility that you have that doesn't transmit, store any kind of PHI or anything like that. Well, there's no sense in putting that in the scope and waste time and resources in going to that facility if it doesn't meet the criteria. Data collection, all right, so we've defined our scope of the security risk analysis. So now we start going into the data collection phase. And what we do when we do our risk assessments is we ask for every policy and procedure that's out there. We ask for any previous reports that were done. We ask for any kind of plans, whether it's incident response, disaster recovery, business continuity. We ask for test results of any of those plans, any and all information that talks about your environment. We ask for that data. And for some of the smaller organizations that are in the room, this is not going to be a huge list of things. Your data collection is probably, it's not going to be insurmountable. So based on that data collection, what you do is you identify and document threats and vulnerabilities. So who can tell me the difference between a vulnerability and a threat? Anybody? Okay.
Vulnerability is a leak. It's already in your system. Right.
Possibly. A vulnerability could be a non-IT issue.
A TrueCrypt is no longer going to be supported because they've identified vulnerabilities in their
Right.
encryption.
Yeah, absolutely.
That would be
So
an
if you
example.
are utilizing TrueCrypt within your environment, then that becomes a vulnerability, right? So a vulnerability is basically it's a way of getting at the data in an undisclosed way. A threat are those people looking to get at that data. All right, so that's the difference. Apparently, I keep on pressing buttons when I'm turning around. So you assess current security measures. Do you use encryption? What kind of network security measures do you have? Do you have a firewall? Do you have some kind of web appliance that filters your web traffic or your email traffic looking for any kind of sensitive information or even malware? You want to assess all those security measures because what you ultimately want to do, you take 1 plus 1 and then you equal 2. Determine the likelihood of that threat being realized. Okay, so if you say you have a bunch of staff members that use mobile devices, right, and they're out on the streets and they're meeting patients in their homes and they're collecting patient information on those mobile devices, whether it's a tablet, a phone, a laptop, or what have you, there's a vulnerability there. I just told you about a stat about people losing laptops, 12,000 in a week. There's a vulnerability there. So that's the vulnerability. But we use encryption, something different than TrueCrypt. We use encryption to encrypt all that data, right? So the likelihood of the threat, actually, let me step back. So this is also a 1. So you got 1 plus 1 plus 1, likelihood of a threat. So what are the chances of that laptop or device being lost or stolen? Possibly pretty high. So you have to analyze what that threat may be. And here it is, the potential impact. So what are we doing, what would the impact of that threat being realized or that vulnerability being realized have on the organization? Okay, and based on that, you're going to determine your level of risk. So a lot of people use probability versus impact, and that's how you derive risk. For those of you who have any kind of government background, NIST, National Institute of Standards and Technology, they have their own risk methodology that talks about probability versus impact. So is this vulnerability a high risk? So that's kind of the process you have to go through for all the vulnerabilities that you identify. It seems pretty cumbersome, but once you get through it once, you can do that review and make sure nothing has changed. So the first one's going to be kind of a heavy lift, but after that, unless there's huge changes in your environment, it's not going to be that difficult. Then ultimately, what HHS says you need to do is finalize the documentation. That's that formal process I was talking about, and then periodic reviews and updates. And the best practice for that periodic review is typically annually. All right, so this is a really cool graph that I created because I'm really good at marketing, mostly through PowerPoint. So this is just showing you that process, okay? You want to identify where your sensitive data resides, determine any security controls and or weaknesses, develop the risk, address the risk, and then start all over. And this is that continuous process. Very fancy stuff here. Okay, so one thing that I really want to point out on this slide, because this is also an eye chart, is that for the modified stage 2, objective number 1 is now protect patient information. In previous stages, I think it was core measure 11 for hospitals and core measure 13 for eligible professionals. Now it is number 1. So if they were adding a precedent, which I think this is done on purpose, look at the top priority that they put out there, protecting patient information. And that goes back to all of the things you can do with patient data. This just gives you some more of the details on that objective. All right, so this, go ahead.
So in our small practice, we often have patients who come to our office without an insurance card and or picture ID. By right, they're giving us, maybe they're giving us an ID, but who's to say that it doesn't belong to Joe Blow? You know, is that a risk?
I don't know if that is a risk to the organization. That is a risk to other people potentially. That is a really hard thing to combat because by right, you said you have to treat them and you have to do all the things that you're supposed to do. There's really no way that I know of that there's to kind of circumvent that or correct that. But this goes back to the utopia idea. If we're all doing the right things and protecting patient data, then they wouldn't have the ability to falsify documents or falsify their identity. I mean, it's a really bad answer because I think you're looking for me to tell you how to stop them and know that they're not who they say they are.
Yeah, but I was just saying from a risk factor point of view, could you turn that patient away until they could provide that?
I don't think I'm qualified to answer that question because I think you're required to treat that patient, especially in an emergency.
Yeah, but the federal government is asking us to protect, but how can I protect if I don't know if that person coming to our window is actually the person who they say they are?
Does anybody else in the room have a similar experience? For some of the smaller practices, I think you can tell people you don't want, you're not going to treat them, correct? I don't know.
Would that cover a risk factor? Security
It would
risk
just be
factor?
worked into your policy that you prefer to have that
Yeah,
as part of your policy.
we do have that,
Yeah, and it does say it'll protect you. I mean, there's nothing you can do. Again, health
Yeah.
insurance cards are always passed around.
Yeah, it starts with policy. So if your policy is that they have to provide a proof of identity, then you can turn them away. But then, me being the auditor and security person, I would want to see the organization kind of monitoring against that. So is there a way to measure the effectiveness of your policy? Are your staff members doing it really is what I'm getting at. Is there a way to measure that? Is there a way to capture that kind of data? We had 4 people come in today without an ID.
Oh, I see.
Do you know what I mean?
Yes, yep,
These are the actions we took.
okay.
Okay, so again, when you get a copy of the slides, it'll be a lot easier to read this. Really, all this is doing for you is giving you examples of different security measures based on the criteria. Physical safeguards, one example is building alarm systems. Administrative safeguards, staff training, love staff training. Technical safeguards, talks about passwords, virus checks, encryption. Policies and procedures, please have some. Organizational requirements. Your business associate agreements, make sure they have some kind of clause for security and privacy when it comes to dealing with those business associates. Okay. So, Blueprint goes into a lot of different types of organizations, different sizes, different business capacities, all within the healthcare industry. And we typically see the same things over and over again. Ineffective security awareness training, organizational policies and procedures that don't necessarily even capture the way the organization is doing business today, system configurations and maintenance, and that goes into the patch management that I mentioned earlier. But I really want to highlight ineffective security awareness training. hospital organization after organization I go into, I find PHI left in exam rooms. Nobody's there. I find PHI left on printer trays for hours, right? I walk into an exam room, the workstation is logged into with a valid nurse or PA's credentials, nobody in the room. Logged into the EHR also. So that is an issue with the training program. Everybody knows that they shouldn't leave PHI in printer trays or in exam rooms. Everybody knows that if they walk away from their workstation, they should lock it out or log out, but they're not doing it. So the security training program needs to focus on not just your staff members, the people who are interacting with the patients, but also your managers, your mid-level managers, the people who are supervising those junior staff members. So if they see it, what are they doing to address those issues? Because a lot of times they're not really doing anything. So one phrase that I learned in the Army that I absolutely love, and I talk about it just about every day, and my wife hates it, is doers do what checkers check, right? So if managers are not checking on their staff members, then the staff members are not going to do what they need them to do. Okay, so the security awareness training program needs to go beyond your annual requirement saying disclosing PHI is bad and lock out of your, when you walk away from your workstation, lock it out. It needs to be interactive. It needs to be engaging. It needs to get people's heart beating to do the right things when it comes to security and privacy, okay? One thing that I always recommend to mostly bigger organizations that have the resources is you should be getting out into the population of your organization and talking to people as frequently as possible. Because if you're only checking the block once a year with, training modules or things like that, those other 364 days, people are not thinking about you, all right? And I want people to think about me all the time, only in nice ways. All right, so it needs to be engaging. You need to get out there, you need to talk to people, and I know none of you are security professionals, but each one of you have a role and a stake in protecting patients, right? So talk about the things that you know well. And if you don't have the answers, get with the folks at MeHI. They can get you in touch with me or anybody else who can answer your questions. And this is, I think, actually the last slide. All right, so here's some links that you can all visit to hopefully get some of your questions answered. I can tell you that some of these websites are really handy. Some of them are kind of tough and you have to navigate them to try to find the answers you're looking for. HHS actually, or CMS actually has a frequently asked questions page. It's not easy to navigate, but if you know some of those keywords of what you're looking for, it's pretty useful because they do answer a lot of questions on there. You just need to know how to get to that information. Okay, I'm going to breeze. Do you want to talk about the members portal or anything with that?
No.
Okay. All right. Questions? Yes, ma'am.
With the business associate agreement, we're doing teleconferencing. We're going through Microsoft. So they wanted us to sign it, but they said that the fact that it was on the computer was sort of their signature. Is that valid, or do they have to have a signature from somebody in the company?
So you don't have a BAA signed currently, or
We do not. We're trying to do this with them.
are you already passing sensitive data?
No.
Okay. Usually the BAAs are signed by all the organizations or all the parties that would be involved in that piece of the pie, whatever it may be. If you're teleconferencing with an organization to, I don't know, do information sharing on a particular research study or what have you, then everybody who's a part of that research study needs to have a BAA for that scenario. Is that, I don't know if I'm answering your
But
question.
you have to have, the question is, do you have to have an actual signature from that company? Because they're telling us that the fact that we go online and there's a contract and we're signing it, it's valid without a representative from Microsoft itself signing it.
So is it a one-way contract? Because I would say yes, you should try to get a signature at all costs, because then and I'm not a lawyer, so I don't wanna speak out of turn, but getting a signature from somebody makes it official for both parties. So I would push for a signature.
So Ryan, I have a hosted EHR that's hosted on their data center. How much do I have to kind of dig into their security as opposed to my BAA kind of that says that they're doing the things they need to do to protect that data?
It's a great question, because the whole cloud concept, healthcare is slow to adopt, but it's coming. People don't realize how quickly it's coming. My best advice to you would be to review the materials that your business associate provides from a security and privacy perspective, but then also do I don't want to say cursory analysis. Send them a list of questions of things that you think you need to get addressed. So you being proactive in assessing their security. I wouldn't go to their data center and be looking for man traps and physical safeguards. Do they have badges? Do they have a visitor's log and all those things? To me, their materials that say that they're doing these things, especially if they're like, what they always say they're HIPAA certified. If they've got that, then that's like the 90% solution. I would get with your account manager and say, hey, here's a list of questions that I need your team to answer.
So just check that they have like intrusion prevention, detection, all that good stuff, you know. Because I mean, they're not really going to tell me what they use, what they use for systems, really, because I don't want people to know that, right? On some levels, because they don't want people to know.
Yeah, well, they're not going to give you the minute details,
Right.
but they'll tell you that
Right.
they have intrusion prevention, intrusion detection.
Right.
They secure themselves with X, Y, and Z. They should have all that information readily available to you. But me doing my due diligence, I would try to dig into some of those for them to give you some of those answers.
Okay.
Do you know what I mean?
Yeah. Thank you.
Any other questions? I hope this has been as much informative as it has been as entertaining. Because I told you, all the security training is all about being engaging and getting people interested. So,
Can I ask one more question?
Absolutely.
Have you seen a good like risk analysis template out there that on any of the ONC?
so
ONC's is huge, it's like 150 some odd questions.
I don't want to
No, we trimmed it
well, like a
down.
template to identify your,
Yeah.
your vulnerabilities.
Yeah, some places.
So MeHI actually has made a tool available from Blueprint called Security Connect, and I believe there's 48 questions.
53 questions.
53 questions. So
That's the way you use it.
right, so you can use this to help you identify any risks or vulnerabilities to your organization. It should take, if you're proactive and you have the information up front that you need, it can take you less than an hour to complete it. And again, it'll give you that starting point, because it's all about that continuous process, right? So this is going to show you some places that you're vulnerable, or you need to address, and then you actually need to address them.
I'd also say too, just adding on to that, is completing the security risk analysis through Security Connect sort of helps in some of the other issues that come later on when you try to attest around supporting documentation. So people are conducting the security risk analyses, and what they're submitting when they attest, with their application, a lot of times is insufficient. It doesn't provide the information around the specific safeguards, specific categories, et cetera. But using this tool, once you complete it appropriately and you complete the remediation plan that goes along with it, it's going to cover you for what's required for supporting documentation.
I know we have one more question, but before we get to that, I just want to make one more comment. If you ever find yourself wondering how much information you should provide, my best advice whenever you're dealing with an auditor or potentially dealing with an auditor is overwhelm them with information. Make a binder this big of stuff, and
That's
I
what we
guarantee
do.
they will go away.
Yeah, that's what we do, I'm a consultant, and that's what we do, we have a binder for each client, and basically you can do like yes and no, but you need to say yes, and this is how we're doing it, because they're gonna ask the question.
The more information, the better. Get into the details, bore them with information. I'm serious, this is a play on human nature, and I'm not trying to teach you how to skirt the system. but I'm trying to teach you how to skirt the system. This is a play on human nature. They will not read every single word if you have a binder this thick, okay? You want?
I'm sorry, I had to step out for a minute, so you may have covered this, if so, just let me know and I'll talk to you one-on-one. Did you go over any major changes that occurred in the way that you gotta do this, based on this new meaningful use modification, stage 2 modified?
I kind of glossed over it, and all I really, the requirements haven't changed, because really all meaningful use does is it points back to the code for federal regulation that you see for HIPAA, talking about those administrative, physical,
Yeah.
technical safeguards, all those things. So, meaningful use has not increased the things you need to do, except for it really just tells you need to have some kind of encryption solution for data in transit, data at rest. The only thing it really did do, and of significance, is it changed the precedent of protecting patient information. It's put it right at the top to try to open people's eyes. But from a security risk analysis or even a process perspective, it really hasn't changed.
No technical changes.
Any other questions? All right, thank you very much.
Thank you.
Thanks.
Thank you.